Hey, Dr. Cindy here with another episode of Essential Therapies podcast. And in this episode, I'm talking with Jane Franczak from CMTPT. Jane is also a women's health physical therapist who uses the John F. Barnes myofascial release approach along with traditional pelvic floor physical therapy. So Jane and I have a good time in this episode talking about what we do best, and that is using the John Barnes approach and applying it to the world of physical therapy, especially when it comes to women's health. I hope you enjoy this episode with Jane. Cindy Hodgson here with Essential Therapies. Thanks for joining in and watching this special call, everybody. I have another myofascial release women's health expert, Jane Franczak, and she's a wonderful, wonderful spirit person, therapist who I just recently met in Delaware, of all places, at the cervical thoracic course with the myofascial release seminars that I retook, and she was teaching there. So Jane, welcome.
Thank you. It's nice to be here.
And so we were just chatting at the seminar, and like, would it be so cool if we could just go live on Facebook and talk to other women about women's health and myofascial release? Because Jane has an incredible resume of working with women and all of the courses that she has taken in traditional women's health and traditional women's physical therapy, which I have not had. So I've been doing women's health and specializing in women's health for over 20 years, but it's really been primarily with the myofascial release base using John Barnes' myofascial release approach and a few other trainings that I've had with women's health. But Jane, I would love for you just to tell everybody who's going to be watching this where your background comes from, how you got into women's health, and how we talked briefly about how you're doing the traditional women's health along with John Barnes. So share with everyone.
Sure. Thanks, Cindy. So I've been a physical therapist for 30 years, and I was working for John Barnes at the Myofascial Release Treatment Center in Sedona. And at some point, we started learning how to treat the pelvic floor. So a year or 2 years later, I suppose, I found myself in a different location, a different state, and my employer was encouraging me to do women's health for them. And I found out that there was a course back home in Baltimore, Maryland, and they would pay for me to go there. So it was at Johns Hopkins, and it was before there was a section on women's health and a Herman and Wallace. So I took that course, and my interest was piqued. And long story short, I eventually started taking more and more classes, designing a niche for myself, and went through all of the section on women's health, which I guess now is called the Pelvic Health Academy. Went through all of their classes, got my certificate of achievement, did the testing and all of the requirements for that, and continued to fast forward, eventually found my way to working at Johns Hopkins in Lutherville, Maryland, and was encouraged to get my women's clinical specialist board certification. So after many months of studying for that and a very difficult exam, I did that, passed that board exam, and eventually was an item writer for the board certification. So
wow.
At this point,
you've done a lot of stuff in women's health. That's amazing.
So at this point, now I use all of those traditional physical therapy, pelvic health training, as well as everything that we learn through the John Barnes myofascial release courses to be able to treat my patients in a more holistic way.
Yeah. That's great. So how would you speak to someone? And one of the main reasons why I wanted to do this video also was to speak to those women out there who don't even know that this work exists. It still happens to me frequently. I'm sure it does to you too, where I'll come across someone and it might be a patient who's there for something else, not for pelvic stuff, maybe, even a shoulder, jaw, hip, who knows. And it will come up that I feel that they might need some of this work. And as I start to explain about women's pelvic floor therapy with myofascial release, there's just like this kind of deer in the headlights look, like, you do what, right? Do you experience this as well?
Yeah, I certainly do. And I'm laughing because I think of one person who had back pain. She was coming in for that and wanted myofascial release. And at some point I suggested that I thought there was a link to her pelvic floor as well as her hip rotator, her obturator internus, and suggested that I really needed to treat that region. And she was very funny about it and said, I can't believe you're suggesting this really crazy thing to me. You know, all I wanted was myofascial release, and you have these crazy ideas of what you want to do. So a lot of times there's a lot of education for clients to be able to help them to understand that it's not crazy, and that this is actually musculature, skeletal muscle that sits inside of our pelvic floor, and our hip rotators, some are on the outside of our pelvis and some are on the inside. And we still need to treat those.
Yeah.
And
it's a real thing. It's a real thing.
Right.
So,
right.
you know, and let's just be completely transparent here. So what we're talking about, and you've got your pelvis, so maybe you can show that here too in a minute, like not your pelvis, but I mean your pelvis model. Is that just with a gloved hand and proper lubrication, we will examine and explore externally around the pelvic floor and internally by using one or two fingers, going vaginally or rectally to explore the tissue and see what needs treated. So it's out there. That's what we're doing. And it's not like going for your annual exam where they're using a speculum and it's uncomfortable and painful and quick. It's completely different than that. And most of the time, I mean, I think I've ever had someone say anything other than this, wow, that wasn't as bad as I thought. And wow, I really needed it, you know? So what would you like to add to that, Jane? And
yeah, I'm going to pull the pelvis model out. So this is a female pelvis. See if I can get it in the picture the right way. And it's got the musculature attached. So you can look inside of that pelvis and see the muscles. You can see where this round hole would be the rectum. This square hole, I don't know if you can see that, is the vagina. And there's a yellow hole, which is the urethra or the P tube. We can look at it from the bottom, seeing the labia and the external muscles to the pelvic floor. And of course, then see our sacroiliac joint. So if you think of, oh, and here's the hip rotator that I spoke of before. You know, so a lot of people are familiar with their pelvis becoming unlevel, sitting higher on one side or maybe rotating forward. So remember the connections that are inside and think about if this pelvis is unlevel, that those muscles are going to be pulled one way. So maybe they're being pulled longer on one side, but then they're shortened on the other. And that's going to cause a unbalance between the muscles. Well, we can go in with gloved hand on females vaginally or rectally, on a man just rectally, and we can get to the muscles of the pelvic floor. So taking my pelvis apart here, you know, if we imagine that we're coming in through the introitus, the opening here, that's going to lead us into the pelvic floor that I just took out. So now we can get to all the different muscles, all the depth of that, treating the tailbone directly, coming around the sides, coming up higher, and working on those trigger points and those tight regions that have formed inside of that pelvis.
The other thing that I love to, when we're doing this work, we also can get on the inside of the piriformis. So, you know, a lot of people are very familiar with the piriformis because it causes a lot of problems, and they're always thinking of the sciatic, and they're thinking of reaching it from the buttocks area, right? And so when we can get on the front side where it comes around and it attaches to the front of the sacrum from doing internal work, it's amazing. And so one of the things, and I'm sure you've heard this too, where I could be working on a patient, you're speaking of yours that came with a back pain, and maybe they're laying there on the table without having any symptom at the moment. We're doing the treatment. All of a sudden, as we're exploring and treating, that's my back pain. Have you ever had that happen? Like you get to that trigger point, and it's like, whoa, there's the pain I've been having for months, years, maybe. And it's actually originating from the pelvic floor.
That's right. Yeah, I'm going to put the pelvic floor back inside of the pelvis just for another example. One of the places, if we look, I'm not sure if I can get this to show the right way, but if you look
Give
at
it
the
a little towards your face. Yeah, there we go.
pelvis this way, and we're going to look on the side. So this would be a person in sideline, and the musculature that is right here is the obturator internus, this hip rotator. So we can certainly palpate externally and decide if that has a trigger point or tenderness, that's maybe an indicator that we need to treat inside. So a lot of times I may palpate that region, or of course that piriformis, as you're saying, and show them that I'm only able externally to access this much of that muscle. The muscle is more like this long. So if we can go inside, we can really get to that hip pain or that back pain, but we're doing a disservice by staying externally and only reaching this much of it.
Yes, so true. Not to mention everything else that's there. So one of the things people may wonder is, what is this helping? So we talked about back pain, but look how close the hip is, and so many areas. But what are some of the things that you've treated, and then we can both kind of chime in some of our success stories, maybe that come to mind that people might be surprised by.
Yeah, so some of the things that people are coming for, of course, is the incontinence or leakage, urinary or fecal incontinence. There may be pelvic pain or painful intercourse. And then there's all of the nerve issues. So pudendal neuralgia, obturator neuralgia, constipation, things like that. So I had a woman who came in this morning with pelvic pain, painful intercourse, and a diastasis rectus. So her abdominal muscles were separated, but it's not just about trying to get them more closely together. We have to look at this entire cylinder of respiratory diaphragm all the way down to the pelvis, the front of her abdomen and the back of her, because there's a link in that whole cylinder. And if we think of that cylinder where there's tension in there, everything that's in between there is going to be under tension and nothing's going to work right. So being able to get at all of that and seeing what are the multifaceted components that are going on inside the body from respiratory diaphragm down to pelvic floor.
Exactly. And so most people don't know that this all works together very, very uniquely in the respiratory diaphragm and the pelvic diaphragm, and just things that we take for granted, just breathing alone, that there is a method to how this all works, and it incorporates the pelvic floor. And if it's restricted, then it's not going to work well, for sure. So those are some of the common things that you would think of that is what people would seek out a pelvic floor therapist for. I often see things like pelvic is connected to the hip, for example, hip pain. They might not be having pelvic pain at all. They might not even be having any incontinence issues whatsoever, but that restriction in the pelvic floor is there, and it's causing hip pain instead, or back pain, or maybe even foot pain. That's right. I've been working, in fact, I was working on somebody the other day. I was on the pelvic floor and she was feeling it in her jaw. So the pelvis is very closely connected to the head and neck area, especially the jaw, TMJ area. So there could be areas there that are connected to the pelvic floor, and maybe you're treating here, but you're not quite getting it all. And then we add the pelvic floor in because there may be a connection, and then we have a change. Oh, headaches and coccyx. Have you seen that?
John Barnes our teacher likes to talk about the 3 Ps, the pterygoids, the psoas, and the piriformis, but I like to add 4 Ps and make the 4th P the pelvic floor. Yeah. So most of my patients who have pelvic floor tension, I want to treat their pterygoids, their jaw clenchers, because if you're clenching up here, you're going to clench in that psoas, in that piriformis, and in that pelvic floor. And I'll ask them, do you clench at night? I'll ask my pelvic floor patients, do you clench at night? And they say, how did you know that? I wake up with headaches and my jaw is really hurting me. How'd you know that? But it's those 4 Ps that we like to associate together.
Right. I know every time I've taken John's women's health course a few times, and every time I take it, I'm reminded, even though I've been doing this work for so long, how important it is to address this area. And it's just kind of mind blowing that it's ignored. And when you think about how many women have gone through procedures, such as everything from an episiotomy, which is cutting that pelvic, the perineum for delivery, to C-sections, to any type of other abdominal procedures like laparoscopic anything. I had an ovarian cyst that needed removal, so that was also exposing that
Mhm.
area, and a trauma that can create scar tissue. There's also endometriosis, which creates scar tissue
Right.
throughout the whole abdomen, and sometimes even further. And so that whole area is very restricted. I spent a lot of time working only on a group, women who were having pelvic issues and infertility issues and so on. And we saw so much endometriosis, which causes also back pain, hip pain, even neck pain, and it can be relieved with this work. So there's so many things. So I would encourage women to, if they've had any of these problems and they're not like fully better, maybe they've done different types of treatment and it's not quite there. And if you haven't had this work done, definitely seek out a therapist who uses this type of approach. So in that thought, did we say all the diagnoses we can think of, you think, Jane?
Oh my gosh, all that we can think of.
Yeah,
Whew,
there's
there's
so
a lot.
many, right? Um,
Even just, I just wanted to say, you talked about the C-section, so
yeah.
cesarean section. So a lot of those women who have a C-section have painful scars. And when we, yeah, I did as well.
Mhm.
When you think about those scars, they're like a seam that they've put inside of your body. And the scar is never just the external part. There's these spider webs and these linkages that go deep inside of the body, and they can and wrap around your organs that are inside, your bladder, your uterus, your intestines. So being able to get in at those scars and help things to function better. Or I've had a few CrossFitters who have come in, and they're young ladies, and they say, I just don't like the little pooch I get around my C-section scar. So maybe they had nothing going wrong, but it was appearances that they didn't care for. And it was able to help their scar to move better and to be, have their belly be more flat. But from my perspective, I know that it's going to help them down the road to prevent any issues that could come up from that tension in there.
So true. And I love that, because I had an experience myself having two C-sections. The second one, it took him a while, the doctor, to kind of sew things up. And he finally like looks over the thing and say, hey, sorry it's taken so long. I'm clearing off all the scar tissue around your bladder. I'm like, oh, great. It had only been 18 months. Previous one, so, but the point being that there's so much more below that scar that is not acknowledged even by physicians. And so you're probably the same way. As therapists, we are very sensitive to touch and what we can feel inside our own body. So I can feel that tension often, and I have to self-treat often with the small ball and get treated whenever I can. But here's an
Mhm.
interesting thing that happened in cervical thoracic, the course that we did a couple weeks ago. And this happened a previous time that I took it, a few years after I had the kids. So when I'm treated here in the neck, in front of the cervical spine, like the anterior portion of the neck, I immediately feel it in the right side of my C-section scar. So,
Mhm.
that's kind of mind blowing probably for people, like, what, how can you get treatment here? And it happens every time. I feel that connection right down to that space. So when, talking about where is this traveling, who knows? I mean, it seems
Right.
logical that it's down here, but it could be even further. So just, we act like it's no big deal. A C-section. Oh yeah, C-section, nothing. I mean, it's a major ordeal, right?
That's right. Yeah, and I just wanted to add that so with my traditional training that I have, we tend to talk more in diagnoses as traditional therapy. And John tends to talk more about that hot, hard, or tender region, anything that's restricted. So I blend those two together, knowing what are the symptoms of that presentation or of that diagnosis. How does it present?
Mhm.
So let's take, for example, pudendal neuralgia. So somebody who's got pain in their pelvic region, um, could it be a pudendal neuralgia? Well, if we know that pudendal neuralgia tends to present with increased pain in sitting, Sometimes it feels like you have increased need to urinate, or perhaps you feel like you're on the edge of an orgasm. You just can't quite get over the edge. Pain with going up and down stairs, those types of things. So a lot of the urologists or the urogynes don't recognize that. And if we can look at what are their symptoms, what are their signs that they're presenting with, then we can work backwards and see what's going on with that pelvis. Is it rotated? Is the sacrum torsioned where all the nerves are coming out? And then what's happening inside of that pelvic floor that could be tractioning that nerve or could be compressing that nerve. And putting both pieces, the orthopedic component, that traditional physical therapy, together with that myofascial release, helping to take the pressure off those nerves, helping to get the nerves to glide better. So blending all of that together so that that person has this very complete picture. And back to traditional therapy, what behaviors are they to avoid or should they do so that they can offset aggravating that nerve condition? Do we want them to sit a lot or not sit a lot? Do we want them to exercise? What kind of stretches do we want them to do? What are those things that they can be doing on their own when they're not in treatment with us that are their behaviors and their habits that may be aggravating that condition or that could help improve it? Right. So I take a lot of those components and I put them together so that education piece is there. And we're really teasing through that puzzle, realizing why they have the issue that is going on for them.
Yeah. Could you show on the model there again, just kind of point out where the pudendal, well, actually that's a good model too, but the pelvis, where the pudendal nerve goes. Because I think people are kind of aware they've heard of this before, and I've had a lot of patients ask about it. So show them on there where that is. Yeah, try. Yeah.
So the pudendal nerve comes out of S234. So these are this is your sacrum, and your sacral segments. S2 would be about here, 3, 4. So they blend together and they're going to dive down into the pelvis. So coming below the pelvic floor, but just inside of where that muscle comes, this is the obturator internus, and it comes up to, I'm looking at this backwards, it comes here. So this pudendal nerve comes out of here, comes around by the piriformis, dives down into here. And then if I turn that, and I'm going to show you inside, that nerve is then going to start to appear. Can you see that pen coming through?
Yep.
So it's coming through right under these pelvic floor muscles and up towards the pubic ridge. So it can get hung up in numerous places inside of there. Well, if your sacrum has a torsion, we're going to need to improve the mobility through there. If your piriformis is in spasm, it could compress it. If your pelvic floor muscles are in spasm, they can also compress it and traction it. And then it can get it hung up here by the pubic ridge. So any of those places where it innervates, which is the labia, the musculature through here, or for a man, it would be the penis and scrotum. It's going and has branches coming into there. So sometimes people will say, I had a young man who came in who had ongoing pain in his penis, worsened by orgasm. Orgasm is a contraction of those muscles, which is then putting more pressure on that nerve. So one of the treatments is we have to avoid orgasm for now until we make them better. He was doing stair stepper exercise rather than running. And I said, good Lord, go back to running, quit the stair stepper.
Yeah.
He sits for work. He's an engineer, so looking again at those pieces and what is aggravating this so that we can start to tease it out and make a complete improvement for them.
Yeah, let's talk about the muscle aspect again, as far as in a lot of traditional physical therapy in general, even just regular orthopedic, almost the first go-to is like what needs strengthened, right? And because they're not thinking about the myofascial restriction that could be there, right? So in terms of pelvic floor and the pelvic restriction that could be there from the fascia compared to the strengthening issue, which is always like, and I hear this often from my patients. Oh, my doctor told me to do Kegels. Like, first of all, I don't even know how to do a Kegel properly. And then right. Maybe they shouldn't even be doing them at all. So I'll let you speak to that.
Sure. I'm going to back up and say, let's think about what is strength. Well, it's a name we use for force, and power equals force times distance. So if we've got a muscle that's too short, you'd have to have superhuman force to get the same power. So if we look at a bicep and I've shortened my bicep completely, that distance is too short. I need superhuman force to get the power to lift my suitcase. So instead of having superhuman force, because most people are pretty strong, let's lengthen the muscle and improve that distance. Now that equation of power equals force times distance is going to improve. So with myofascial release, what we're doing is lengthening that distance, lengthening the components of the musculature. Then the force, sometimes we need to re-educate the muscles. We might need to say to them, let's get the timing and the control. Let's get your connection to that muscle to work better so that we can tune things up a bit and get that power better. But when we go right to Kegels, first of all, if the muscles are too short, you can't get that muscle to shorten any further. So you need to restore length before you go to doing strength. Yeah. So let's restore the length. Let's get the motion happening. Let's re-educate you so you can now connect your brain and what you desire to do with the muscle. Let's get that connection reestablished to the muscle. So now you can move. And most of the time, I don't need to improve their strength. I don't need the biofeedback. But for some of them, I do. And we still need to be able to maybe use some biofeedback to get their Kegels, which are really pelvic floor muscle exercises, to get them to be able to understand them. And then going back to traditional therapy, how long do they hold those Kegels? How many do they do? How do they advance the program? How do we maintain? Well, all of that needs to be a component in what's going on in their care. But the first thing we have to do is establish the proper distance and force relationship to get the power of those muscles.
Yeah, beautiful. And I love it because I use the same analogy, right? Yeah. Muscle fibers for all of you who know, what are they doing here?
Right. That's right. Yeah.
So, I always talk about like, this is like the muscle, the resting length of the muscle fiber is here, let's say. This is for optimal strength and power, right? So the problem is the fascia is restricting it, is because the fascia is tight, it's cramming those muscle fibers together like this, and it won't let them open up. So that's what we're talking about. Those fibers aren't even able functionally to contract in the way that they're designed. So we need this release technique, and the John Barnes approach requires longer holds on the tissue. We should probably mention that too, because I know a lot of patients will have had, massage, pelvic massage, where they're just kind of, it's more of a kind of kneading, not holding type of technique. And so with myofascial release all throughout the body, we take up the slack, we don't force tissue ever, and we wait for that magic moment when the collagen, as well as the elastic, which will release sooner, but we're waiting for that collagenous component to feel the big difference. And I think that's really what separates us out, don't you think, Jane, from other traditional pelvic floor?
I think it's both. I think it's, yes, releasing that tissue, spending the amount of time that tissue needs all throughout, not just the pelvic floor, but the entire body, the abdomen, the back, the neck, as you said, the dural tube, and spending the amount is needed in those regions. It's, and then actually touching internally in the pelvic floor. I had a person who came to me who had terrible pelvic pain, and he went to 2 different physical therapists. They touched that little piece of the obturator internus, didn't find a tender point, and said, well, we don't need to do any pelvic floor work. Or they just simply balance the pelvis and say, well, that should fix everything. But, think about a rotator cuff. If you have an issue with your rotator cuff, would you ever expect to see the therapist and not have them take your shirt off? They're going to expose the muscle. They want to see how it moves. They want to touch it. They want to feel it. They want to see how everything is moving. We as pelvic floor therapists and we as myofascial release therapists are going to go inside and feel the muscle and feel for those tense areas and take the time that's needed to be able to improve the mobility and release the tissues. Yeah, I think there's a lot that sets us apart, but I'm biased.
Right. So is there anything else that we can say to make it sort of less intimidating or less scary for people? What do you think?
Oh, yeah. So, you know, as pelvic floor therapists, I should say as myofascial therapists,
Right.
we take the time to work with the individual. And I'm thinking back to a client, so I'm trying to put all of this together. So we're going to meet that client where they are, and we're going to help them to understand what's going on and individualize the session for them. So at some point, we do need to evaluate your pelvic floor muscles, but there's so many other things that we can work on before we have to do that internal assessment. And once we do move into the internal assessment and treatment, we're working with you and we're working with the tissue. So it shouldn't be painful or scary. Sometimes it might be painful, I should say. And pain is relative. Pain is your perception of an input. So, but we're not going to force. You're never forced into treatment. The tissue is never forced. And we're working with the timing that the individual is ready for, as well as the timing that the tissue needs to be able to make the right changes.
Mm-hmm. Yeah, that's beautifully said. So true. And it's always, the patient's always in control. That's the other thing.
That's right.
Always. So awesome. Well, this has, I think, been a great introduction. We definitely talked a little longer than we thought we might, but there's so much more to say. So what I think,
so much we could talk about.
Right. So maybe we'll do this again. Well, we talked about that. So if you guys have questions or comments, feel free to leave them here or reach out to either one of us. We'll give our information here too. I would love to make this a regular thing, like even if it's only once a month, to help keep reminding people and educating and giving information just to help. There's so many people out there, I think, who could avoid invasive procedures, everything from hip surgery to, pelvic slings, all kinds of things, right? And people need to know that this is there. So again, I'm from Essential Therapies. So Essential Therapies is in Toledo, Ohio, and Jane is from the Eastern Shore of Maryland. And you want to tell a little bit about your location and the name of your space?
Yeah, so I'm with CMTPT. I am CMTPT, I should say. So I'm on the Eastern Shore of Maryland. I have an office in Kent Island, which is closer to Annapolis. And a lot of people from the greater Baltimore, greater Annapolis area will come and see me there. And then my other office where I am today is in Easton, Maryland, and much closer to the beach resorts, Salisbury, and some of the Delaware areas. So it's gorgeous here on the shore. So come and see me.
I might have to come there for a treatment week in the summer when it's nice.
Lovely. Come see Michael.
Yeah. All right. Well, I think that's it. If there's anything else you want to add, Jane, anything else?
Not right now. I think we covered a lot, Cindy.
Thanks so much for joining us, everyone, and we would love to hear from you. Have a great day. Please like and subscribe if this video was helpful, and do share to someone else who might benefit from this important information on women's health. Thank you so much for watching, and please reach out to either Jane or Cindy. CMTPT on the Maryland coast at 775-690-1211, and Cindy in Toledo, Ohio at Essential Therapies 419-344-2223. Have a great day.